It gives me great pleasure to welcome to the podium Professor Adekunle Adekile, who is the chair of my board at the Global Action Network for Sickle Cell and Other Inherited Blood Disorder. So thank you so much for flying in and being part of our summit. Dr. Adekile, I will say a little bit about him. Graduated from the University of Ibadan Medical School in Nigeria, and also had his pediatric residency training at the OAU University Teaching Hospital, also in Nigeria. It was in Howard University Hospital, Washington, D.C. from 1980 to 1981 for his postdoctoral fellowship in pediatric hematology, during which time he worked at the Comprehensive Sickle Cell Center under Dr. Roland Scott. He also established a sickle cell clinic in the OAU University Teaching Hospital on his return to Nigeria in 1981. Dr. Adekile also worked for many years, about 33 years in Kuwait, and also at that time he was the director of the Kuwait National Sickle Cell Registry, which he established in 2011. He was also active in the hematology profession circles in Arabian Gulf. Dr. Adekile holds a PhD in cell biology from the University of Massachusetts, Netherlands, based on his thesis, Comparative Studies of Nigerians and Kuwaiti Sickle Cell Patients. His research expertise is in the phenotypic variability of the disease, especially the presentation among patients with the Arab/Indian haplotype and elevated hemoglobin F. A little bit more about Dr. Adekile. He was the founding chairman of the Nigerian Sickle Cell Network and the Sickle Cell Support Society of Nigeria. He has more than 160 publications in peer-reviewed journals. He has served as a consultant with WHO. As a matter of fact, and it's not like I'm, tooting your horns, but many of the management protocol for sickle cell in Africa, it is the one that did that for WHO. So it's very well respected at those circles. As a consultant with WHO, HAFRO, on the management of sickle cell in Africa, and is also the current editor-in-chief of Hemoglobin, the International Journal of Hemoglobin Research. So you will agree with me, with his background, that he is worthy to deliver the keynote address this morning on global advocacy, including registry initiatives supporting management of sickle cell disease. Welcome, Professor Adekunle Adekile.
Morning. I'm so delighted to be here in Toronto. This is my first visit. I think I heard of Sickle many years ago, and pre-COVID, Larry invited me to participate on one of the online summit events. And that's when I first got to know her, and she's an awesome lady. I mean, I'm really blown away. I'm really blown away by her energy, her vision, and she just persists and gets things done. So when she called me to join her on Ganseed 2 years ago, I didn't have any hesitation at all. And it's been my great pleasure to serve as the chairman of the board in the last 1 year or so. Now, this is quite an impressive event. And I like the theme, shaping a healthier sickle cell disease community tomorrow through actions today. Now, there's only one thing missing from that, and that is the past. So we have to know where we're coming from to appreciate what we have today and to plan for tomorrow. So I'm going to give you some perspectives in that regard, just to see where are we coming from and where are we today. Oh, okay. So I don't have any disclosures. And we'll talk briefly about the origin of hemoglobin S gene, and then we'll talk about some of the frontiers of knowledge that got us to where we are, and then a little bit about the epidemiology. Then, how did advocacy in the context of sickle cell disease really start? And where are we? And what does it take to be a good advocate? Okay? Then we'll talk about the high prevalence countries which are in Africa, and what are the challenges that they face, and what are the things that can be done to help get things better. And that's where we'll talk about the Gantt model. Okay, now, all of us so-called modern human beings have been in existence for like 50,000 years or so. But before the agricultural revolution, we were nomads, just going and gathering, hunting, and that kind of thing. But with the agricultural revolution, with basic technology, to do farming and all that, there was plenty of food. Okay, so family sizes started to increase, and cities, as we know them today, started to develop, and people started to live in close proximity. And what happened? Infections were transmitted. And as the MP, I was really impressed, said, so one of the big vectors of infection, of course, is the mosquito. And that carried malaria, okay? And more people have been killed by malaria than all the wars, all the famines that we've had in history, okay? Now, nature is fantastic. Now, we know we all accumulate mutations in our DNA from time to time. But when one mutation is advantageous and leads to survival, then it is selected. And that's how sickle cell gene became rampant and prevalent in areas of the world where malaria was endemic. Because if you carry the trait, that is, you are heterozygote, then you survive the disease better. But unfortunately, if you are a homozygote and you inherit 2 sickle genes from your parents, then you are at a disadvantage. And you have all the problems of anemia, recurrent pain crisis, chronic inflammation, okay? And we have complications that affect all organs virtually in the body. We used to think, when DNA recombinant technology started in the 70s, we got to know that sickle cell disease is not completely homogeneous. There are different types when you look at the DNA. And the 3 major types, the Benin, what we call the haplotype, then the Bantu, then the Senegal, and then we had the Arab India, haplotype. So the thinking was that this gene originated, severally, at least on 3 occasions from Africa, and then spread to other parts of the world, okay? However, with new work, we're now thinking that maybe that's not quite true. Just like everything in science, we go back and re-examine, but that is neither here nor there. So what do we have now? The high prevalence countries, like I said before, are mostly in Africa, and this is a cartogram that just shows the relative sizes of the countries compared to, based on the prevalence of this disease, of the gene in that area. So the big guns, Nigeria, DRC, India, okay? And then you can see that the other places like in the Americas, Europe, sickle cell disease got there by slave trade and other migrations, okay? But and this is increasing, it's still growing, and in the next 20, 50 years, it may be completely out of hand if we don't act now, okay? So what do we know, and how did we get here as of now? When you look at the modern medical literature, the first mention of sickle cell disease in the literature was by Dr. Herrick in 1910 when he saw this dental student from the Caribbean, okay? But so after 1910, there were several other reports. So we have what we call the pre-molecular era, and then the molecular era, and then when we start to learn about the pathophysiology of the disease, until now that we have new treatments, okay? Now, the molecular era actually started with the work of this gentleman, Linus Pauling, in 1949. He was the first to actually describe the basic abnormality, that this was a protein abnormality, and that's why sickle cell disease is still considered as the first molecular disease. And it was also the first gene, the globin gene, to be cloned. So all the things we know today about molecular biology actually started with the study of the globin gene, okay? And then we got to know that the sickle cell trait protected against malaria. Electrophoresis was started in 1955. The description of the basic amino acid substitution was in 1957. And then we learned about the structure of the hemoglobin and all that. Now, we needed all this accumulation of knowledge to actually tease out what the problem was, okay? And that's when advocacy really started. And bear in mind, a lot of this work was done in the US. And they still believed that sickle cell was just a disease of the black people. And you know the political and sociological situation in the US in the 50s and 70s, 60s and 70s. I mean, there was sanctioned segregation. So to think that even at that time, people were bold enough to start advocacy, and I was lucky enough to work with Roland Scott in Howard University. He was the doctor that actually led the congressional hearings in Congress about sickle cell disease, which eventually led to the passage of the Sickle Cell Disease Control and Treatment Act by President Nixon in 1972. And, well, before we go on, I just put this on to just remind us that there are complications of sickle cell disease. Some start from childhood, some are more common in the older patients, but virtually every organ that you can think of, from the brain, to the heart, to the lungs, to the spleen, liver, bones, and sexual organs are all affected, okay? And that causes serious morbidity and mortality. Up to today, in Africa, a child with sickle cell disease is more likely to die before the age of 5, okay? Now, this is the US pattern of survival of sickle cell disease, and up till the 60s and 70s, even in the US, the age expectation or the life expectation was still less than 10 years, right? And we had known about the disease, we knew all the science, but until 1970-72, when the act was passed, and the federal government actually committed to having programs. That's when they set up the comprehensive sickle cell centers. That's when they started funding research. That's when we knew that penicillin would protect children from dying before the age of 5, okay? And that's when the survival rate shot up, okay? So that was when the act was passed, penicillin prevention, and eventually hydroxyurea transfusion, and of course, the newer treatments that we have today. Okay, so this is one study that I've really, become a student of. How did they do it in the 50s and 60s in the US to get the federal government to be committed? It was a Republican regime at that time, and to convince them, it took massive, consistent advocacy. And it had to be data-driven. That's why you needed all that scientific build-up to convince people, to give them the right understanding. And that's why up to today, to have effective advocacy, you have to have data, okay? And then you need educated stalwarts, people who are experts. And that means the physicians, the scientists, care providers, and all such people. And you can't do it without getting the public involved, raising awareness, education, okay, and the involvement of icons in society, the arts, culture, sports icons, and the media, print, TV, okay, and now we have social media that's so powerful. We all need to get involved with that and have some kind of expertise. Okay, and then, of course, the community leaders and elders, religious leaders. But all this, you keep trying, the people who can make a change at the end of the day are the policy makers. Okay? But you need all this village behind you to be able to convince the policy makers. And at the end of the day, the people who are the most effective advocates are those that live with the disease themselves, or who have relatives and relations that are affected. And like Larry always says, you keep knocking, you have to be persistent. You don't get what you want at the first try, so you have to be persistent, okay? But there are special problems when you now talk about high prevalence countries. Most of these countries are in the low and middle income areas. They have overwhelming numbers. It's just that, the time given to me is kind of short. I would have given you some slides to show the kind of the numbers that we see in Africa when you have a clinic day and 200 to 300 patients show up and there's only 1 or 2 doctors and 2 nurses to take care of them. I mean, it can be really overwhelming. Then there's poor awareness, lack of trained personnel at all levels, poor infrastructure, and then there's also the combined comorbidities of infections and other problems, okay? Then one of the big cultural issues is that this disease is closed around all kinds of myths. It's some evil spirit or your enemies, they don't like your family and that kind of thing. And then there are all the stigmas. You don't want to talk to that family because they have patients with sickle cell disease there. You can't get married to that family. You can't do this. So that's stigma within the society. Then you go to school. Your peers don't want to, associate with you. They think you are sick. Your eyes are kind of yellow. You're kind of thin or whatever. Okay? And then you get to the hospital. Then you meet all kinds of, whatever. They say you are drug seeking, you're just pretending. So it's a whole slew of negativity. And several people have thought about the issues, including as high as the United Nations and the World Health Organization. And in 2008 was when the WHO decided that, look, sickle cell disease, especially in the high prevalence countries, is a public health problem and has to be looked at as such, okay? And said that countries where you have significant numbers of patients, you must have national policies, you must have certain interventions that must be in place, and then later, WHO launched what they call the Package of Essential NCD Interventions, PEN and PEN+, which is the model for looking after patients with these non-communicable diseases in the community, from the primary health care center to the first referral hospital to the tertiary centers, okay? And recently, sickle cell disease was added to that list of NCDs. Now, in 2022, because in spite of all that the WHO had done and prescribed, many of these countries still were not responding. And that's when the WHO said, okay, look, maybe we have to put down, practical, specific framework on how these things should be tackled. And then they set up a panel of experts, and I was fortunate to lead that panel to deliberate on, okay, in these countries with high prevalence, what should they be doing? And then we said, look, it has to be a pyramidal kind of framework or structure, and as much as possible, patients should be seen as close to where they live as possible. And we're talking about primary healthcare centers, okay? And you have to train the people who are available there to make the diagnosis, to give the routine drugs, to know which patient to send or refer to the secondary healthcare facility, which is usually the district hospital. And at the district hospital level, there must be a certain level of expertise and facilities to be able to manage, the acute and chronic problems that may arise. And then, of course, at the apex is the tertiary center or center of excellence that should be equipped to provide all the treatments, novel therapy and whatever. And from the top down, you have to have monitoring groups, organizing training, and things like that. And this is the hub and spoke or satellite kind of system. The first referral center or the general hospital is there in the center. And this is the satellite of primary care centers. Okay? So these guys here would organize the clinics here, train the people there, okay? And these guys here know when to refer patients to them, and then there must be some kind of monitoring. This is something we were discussing last night. You have to set standards, and you have to monitor and enforce, okay? And you don't want to reinvent the wheel, or you want to maximize or optimize the facilities and personnel that you have. Therefore, there must be integration because there are certain things already in place. The PEM Plus, the maternal and child health care, immunization, HIV, all those programs are already in place. So you try to integrate sickle cell care into those existing programs. For instance, in terms of newborn screening is so important. Now, but in many of these countries, a lot of the births do not necessarily take place in the hospital. They may be in different other places. So you may not be able to capture those kids when they are born. So, but when they come for immunization, is the time that you may, so we now kind of integrate the screening into the immunization program. Okay, so how do we optimize the system that we have? Capacity building, Capacity building, you have to train, you have to raise awareness and educate, you have to do early diagnosis, then, enroll the patients that are identified into comprehensive centers. There must be clear-cut referral pathways, and then you have to have some centers of excellence where all the state-of-the-art therapies can be available. Now, so what does GANSID do? GANSID has been in existence for about 3 years now. It's a network of different organizations, healthcare providers, and including people that live with the disease. Why I like the model is that it's not just sickle cell, it's also other inherited blood disorders. Because in many of the low and middle income countries, the same doctors that look after sickle cell have to look after hemophilia, have to look after, other different types of anemias or other inherited blood disorders like, bone marrow suppression, aplastic anemia, and things like that. So just to maximize the personnel that you have, so you bring them together, okay? And the mission is that it's using data-driven advocacy, to address disease-specific and cross-disease, initiatives, okay? And there are certain programs that GANSID cherishes, and I just talk about 2 of them. One is the clinical trial standardization. Now, we know that 75% of the sickle cell patients live in the low and middle income countries. If you look at the clinical trials that are going on today, less than 5% are based in such countries. And what happens is that you have this, you roll out new treatments, you've not tried them on people from those areas, and you don't know how they're going to respond. And that is a practical and realistic issue because there have been treatments that have been approved, then they get to Africa and people start dying because they were not part of the trial. Okay? So we're now trying to see what are the issues? How do we make this more accessible to more parts of the world? So that's one thing that GANSID is doing. The second thing that I want to talk about is the registry. And we've always stressed that without data, you can't plan. You don't know what the problems, the extent of the problems, okay? And sickle cell disease is so heterogeneous. There are different variants. There are different phenotypes, okay? There are different treatments that are available to different places, okay? So without having a registry, you really can't see, you can't have a broad overview of the problems. And there are, kind of fragmented registries here and there. So we want a global registry that is truly global, and that's what Gansid has been spearheading. We've now identified who is going to, what platform we're going to use, what pilot centers we're going to start with, okay? And that is ongoing, and that is so important for eventual improving outcomes. Okay, so in concluding, to make the most global impact on the management and control of sickle cell disease, our focus, whether we like it or not, has to be on the areas of high prevalence. That's when we really know truly we are making an impact, and it's going to be based on capacity building, early diagnosis, advocacy, and we can't stress enough that the national governments and policymakers have to be involved. They have to set the ball rolling, and hopefully we'll have equitable access to treatment. I think that's my last. Thank you so much.
Thank you very much. Is there any questions for Professor Adekele?
Well, usually they say keynote speakers
Questions?
don't take.
Over here.
Oh, okay, good.
Well, we'll take about 3 questions.
I'm fascinated about the concept of the screening
Yes.
in high prevalence countries where culture brings into question biology versus, discrimination in terms of stigmatization. After you have, let us say that you have put in place screening at birth, what then happens to that mother, to that family that is carrying for 9 months or less? What is the plan? Because here in Canada, yes, we're screened maybe about 2 months in terms of gestation, 2 months into the pregnancy. And we live with whatever comes out of it, whether it's a mistake, which sometimes happens.
Okay. Thank you.
Or if it is true and the doctors say to you, you have a 1 in 8 chance, or I'm talking about just general screening now, not necessarily sickle cell, or you have a 1 in 212 odds of having a child with a disability. So let's say it comes back positive, that you and your spouse are both carriers and the child will have full-blown sickle cell. What will happen in high prevalence countries?
Thank you. Well, that's an excellent question. We just came back when Sierra Leone, not long ago. Now, there was a group in Sierra Leone that got some funding, and then they started screening, right? Now, they identified, I don't know how many affected children, and then they told them, you got to come to the clinic, for your child to be followed. And none of them showed up. Not one, right? The problem is that, you see, when you have a newborn with sickle cell disease, they look healthy. And for the first few months of life, they are growing well, nothing happens. And then you tell this mother that this child is sick. You say, what are you talking about? I can know when my child is sick, right? So we really need a lot of awareness. You need to prepare them. You need to let them know the consequences of the diagnosis. And it's not easy. And this experience is not only Sierra Leone. It happened in Nigeria, it happened in Tanzania, everywhere. You start screening without actually preparing the community, because it's a community affair. You got to go into the community, you got to convince the leaders, the community leaders, the religious leaders, that this is coming, this is the, that sickle cell disease is not a myth, it's not somebody after, it's not an evil spirit. And if the children start treatment early or we identify them early, their chances are much better. So it's a lot of work. It's a challenge. Thank you.
We'll take one more question, because of time. The gentleman.
Thank you very much for your presentation. And because you have this global view, one of the questions I would like to ask is that what's the life expectancy? You said maybe about 5 years initially back in Africa, but what's the life expectancy now? And the other thing I want to say is that everybody is different. It has been an eye-opener for me because while I was in Nigeria, if you're a sickler, everybody will know about it when you stand. But being in Canada, because of the economy and everything, you barely notice anything. And so we are learning how to look after sick people and also how to treat them with respect and dignity. And so I'm very grateful for this opportunity. The life expectancy.
Sure. Again, it's a spectrum, right? There are patients now who survive to their 60s and 70s. But when you take a big overview, and the key thing is early care and interventions. Even in Africa, patients are surviving to their 40s and 50s, routinely. But those are patients who have good care, right? Now, the patients who are in the rural areas who have not been to any clinic, they still die before they are 5 from severe anemia, malaria, and other infections, okay? But in the US now, and I'm sure in Canada, any child born today is almost guaranteed that will become an adult. Okay? Now, we can't say that yet in many other places. Okay? Yeah. So, I think we should focus on care, awareness, okay? And all that good things will follow.
We can take one more question. There's a lady there that wanted to ask a question. Is it a lady or a guy? I'm not sure. Who raised their hand earlier? That's you? Okay, sure. No worries. Thank you.
Definitely a lady.
I know.
Thank you very much for your very informative talk. Johnny with the Canadian Federation of Students Black Caucus. There was a portion that you mentioned around prevalent countries. Now, I'm from DRC, but a lot of us in the room are from African countries like Nigeria. You mentioned India. I don't see a lot of that representation in the room. In your opinion, perhaps as we look into advocacy, what is the best way for us to perhaps tap into those kind of networks if the prevalence in India is as high, for us to create better advocacy? Do you have any opinions on that? Thank you.
Well, thank you so much. Well, you're right. Maybe there aren't many Indians in the room, but India has been very active in the sickle cell world because they have a very high incidence. And the thing in India, just like in the US, is that the high prevalence area is not uniformly distributed in India. It's more in what they call the tribals. And the tribals are the kind of relegated, people who are in the very rural areas. That's where it's very high. But it so happens that the current Prime Minister of India comes from one of those states or areas. So it's been easier to reach him. And India now has a fantastic program, which is very bold, that they want to eradicate sickle cell disease before the year 2047, which will be the 100th year of Indian statehood. And they are doing massive screening. They've set up so many clinics, so they've done a lot. And Larry and I have been in touch with so many centers in India. And the registry that I talked about, we're going to have 2 pilot centers in India. So they're doing quite a lot.
And if I may add to the India thing, one thing that they're also doing in India that was for me, I was very impressed when I met with their Minister of Disability and Social Services, Sir G. Atawala. They have disability program for sickle cell, for hemophilia, thalassemia, all of these programs. And I'm like, How did you guys get so far ahead, like to have that disability program? So if you can work and you have these disorders, you have a government-assisted program to really support you. So India is doing a lot when it comes to sickle cell. Thank you so much, Professor Adekele. That was amazing. Thank you so much.
Thank you.
So I hope you all can see I did not disappoint when I told you you're in for a fun-filled event, right?